Well, good morning. So glad to be here. And this isn't an advertisement for the HICMA program, although it's really a good program. And we all graduated from there. But I tell you, when I first looked at the lineup here, I was kind of questioning, okay, social services, humanities, nonprofits, and mixed with this group. And it reminded me when I got invited up to Oakland to be on a panel presented by Elon Musk. And I went up there and I thought, homelessness, why am I coming up here? And I got up there and there was a group of millennials and early 30s talking about AI, talking about Bitcoins. And I thought, so I figured, well, mixed in, I started talking to them and they're looking at me like, who is this old guy? And I said, I'm going, can I ask a question? What's Bitcoins? And so this was like 5 years ago. So I left that conference thinking to myself, like, did they make a mistake and just put me on there? So I presented and people understood homelessness a bit. But I tell you, moving 5 years forward, people are starting to understand homelessness a lot more. And if they certainly don't understand it, they're seeing it. And I know the first day of the conference was incredible, and we touched on a couple items really lightly. One of them was mental health illness, and I'll get into that in a second. Substance abuse disorders. What we're doing to combat this. And you'll see from our presentation that we wish we could say that we had a strategy that we learned in MBA school, that we set out to do innovative programs to solve homelessness and the cost of homelessness, but that's not reality. Actually, innovation found us, problem solving found us, and moved forward now into where we're at. It's been an incredible 10-year ride. And we actually started in my garage. Dr. Feldstein helped us start the nonprofit and still is on our advisory board. But I tell you, the 10 years and what we learned has been incredible. You can see our growth and how we started to pioneer some of the things that we're using today. And some of the strategies that we're using today are, although productive, and you can see our growth, we're really still a small nonprofit, but we really are poised to grow. And we're poised to grow because we started realizing that we can make an impact on the most vulnerable groups. And I know, again, we touched on them a couple times, but first identifying what the vulnerable groups were was really difficult 10 years ago. We've come a long way, and we'll show you one of the areas that we really worked in, and that is recuperative care. We decided early on we just did not want to be a nonprofit that was taking care of people and just applying for grants. So unbeknownst to us at the time, there was a real problem with discharging homeless patients to the street. And some of the hospitals were getting in a lot of trouble and being fined for it. So when they came to us and said, can you take in some of the recuperative care or some of the patients that were gonna go to the street, we thought about it. And at first we said, well, I was the director of critical care at Saddleback at the time, and I thought, nah, that little cloud comes up over your head where you're saying, I know what it's like having a homeless heroin addict in your ER, and I'm shaking my head no, and the person from the hospital association says, we'll pay you $200 a day. And I said, we'll start tomorrow. And we literally, kind of on the fly, started recuperative care. Unbeknownst to us that there was 4 other recuperative cares in the nation, and the biggest being in Boston. And later we found out, wow, they have a medical respite was similar to what we were calling recuperative care. So these are just some of our numbers, but I want to get right into recuperative care. So what we did is we set up a program where hospitals could discharge patients to us, and they were discharged from the hospital, and all they had to do was do their ADLs, and we can put them in a secure location. At the time, we were using motel rooms, and we would keep them anywhere from 10 to 30 days. And so when we look back and we think, wow, how naive were we to think that we were going to put a heroin addict, substance abuse, schizophrenic in a motel room, and they were going to stay there and get better. But just by doing the housing part of it, we found out that they stabilized them and they were in a safe place. Through the years, we learned to work with them and apply behavioral health policies. We were able to work on their substance abuse. And as we grew, we learned about specialists who could do this better than we could. So we brought them in to take care of this small group at the time of individuals. We were fortunate enough to be able to get a pilot program with UniHealth in St. Joseph's. And you'll see this population where we took in individuals that you'll see on the riverbed, you'll see in the Civic Center. Most of the major cities and even some of the smaller cities across the US are seeing this population. 79% previously substance abuse, 71% mental health condition, and dual, and incarceration. Those were the clients that we were seeing. We actually took in at the time 38 clients, or 38 clients, and we put them in housing for 2 years and did all the wraparound services with them. And we'll show you some of the outcomes. Or actually, this is what we actually did. Those are the services that we gave. And we addressed housing, behavioral health, and substance abuse. And all the intangibles like transportation that you really don't think about, but our clients couldn't get to their appointments even if they wanted to. So after 2 years, we started looking at the outcomes. And if you look at these outcomes, they're pretty incredible. And the number where we estimated $7 million in medical cost avoidance, like we talked about yesterday, we didn't say it was cost savings because people would want that money back. It was cost avoidance. And hospitals were reluctant also to tell us, oh yeah, we saved this money. But we had the advantage of using CalOptima to verify some of these numbers that we have. We've since really increased this program. We now work with all St. Joseph's hospital systems. We work with Hoag, we work with St. Jude's, and now we're taking in 108 patients. We're taking them in for 3 years, giving them permanent housing, and doing all the wraparound services. We already can tell in the first year that these numbers are going to really increase in savings and effectiveness of getting these people into individual housing. So UCI and the United Way of Orange County did a study. And if you look at these numbers, $299 million are being spent annually to take care of the homeless. And it's incredible. When we looked at these numbers, even though we had a small, tiny population we were looking at, we realized that they mirrored this. The savings that we were seeing and the cost avoidance were mirroring these numbers almost exactly. And just by a benefit of putting people into housing, giving them efficient wraparound services is going to pay an incredible dividend. And numbers that HUD and HRSA show across the nation show that same thing. And when you start to think about it, we kept thinking, what industry, engineering, business, any industry that shows you have this kind of cost and you have a return on your investment and you could save this money, why wouldn't you implement something immediately? Like, why wouldn't you just start tomorrow and say, like, hey, we can save monies. Let's put some budget in there. Let's do the wraparound services. So, obviously the stigma of homelessness and people not understanding mental illness and substance abuse has hit a crisis state that we're in now. I said something the other day to a reporter, And I said, arguably, homelessness is a crisis, a social crisis that could define our generation. And he said, you really think that? And I said, yes. I said, because 10 years ago, we would be working with hundreds, maybe thousands. Now we're working with tens of thousands of people. And anybody that lives in Orange County can read about the riverbed and the way we handled that fiasco. We took some of the people out of the riverbed that were homeless and are paying millions of dollars to put 400 people in a motel for 30 days, 60 days. It was a judge-ordered move that the county did. We were part of that, and I have to tell you, we're almost ashamed to be part of it because it's a Band-Aid, and we're putting people that are, some are mentally ill, some have substance abuse, into motels for a temporary fix, and then we're gonna move them all out in 30 days. And you know what? They're gonna be scattered in Newport Beach, in Mission Viejo, in every city that all of us live in here. So when we say it's a crisis, we can see it coming. 10 years ago, we never thought we would be here. We really thought we were gonna connect some people to health services, get an A on our project, and be done. Again, another way to show homelessness and the cost. So not only is it the right thing to do and the ethical thing to do, fiscally, we can show that the return on investment is really where we need to be pointing our money. But more than that, I think all of us in this room, and I'll tell you about it in a second, need to be able to participate. You know, it has to be a three-pronged approach. It really has to be business, it has to be civic leaders, and it has to be the community. So a few things we are innovative about, and one of them is housing. We can show that if you house somebody, and I think some of you may have heard about permanent housing, housing first, rapid rehousing. Obviously, with the market of 2% vacancy, it's really difficult to try to get a homeless person into housing. We worked with the program that put in container housing, and for a while that looked like it was going to be an answer, shipping containers, Potter's Lanes in Westminster, Midway City. We moved some veterans in there. It looked like it might be an answer, but the cost was just prohibitive. And so we kept looking for different and imaginative ways to create housing, and we stumbled across an architect who had done modular housing. And he had built this housing that you're seeing right now in the Amazon. It actually floats. It's the third of a price of conventional housing. And we're working with cities in Orange County, LA, and Inland Empire to get reclaimed land that they're not using. And in 1 week, we can put this modular housing on there. We're probably about 8 months away from actually getting our first prototype, but it could be the answer to creating more housing. This, along with micro communities, we're purchasing housing, 4 and 5 bedroom houses that were then kind of like Match.com. We're moving homeless people immediately into housing. And currently we have about 47 houses. And I dare to say they're in your neighborhoods, and you probably don't even know our population is there. Our life expectancy is 83 years old. The life expectancy of a homeless individual is 48. The average people that we're getting in, their age is 45. So we're not talking about like teenagers like my next door neighbors that are up in 2 in the morning. They're in bed by 8 o'clock. And we're dealing with seniors. So when we move them into these houses, give them wraparound care, adjust their medications if they're mental health. 50% of the people we say we get them to try to stop medication. The other 50% we get them to take medication. It works. It works. We've figured out a solution that works, and it's not easy, and it's not quick, but it's really effective. We talked all around this the other day about social determinants of health. They didn't mention that, but that's what they are. And I think everybody in this room, and I think it was mentioned a couple times, it's not the broken leg, it's not the CHF, it's not the diabetes so much, it's the 70% social barriers that are creating the barriers to access to health. And so it's just starting to become on a lot of radars from different hospitals, and we've been talking to hospital administrators saying, this is what we do. And I heard a physician who treats homeless talk the other day, and he said, people come to us when they can't do anything else, when they're broke, when they can't walk. They could have a broken leg and they'll continue to do what they're doing. They come to us when stuff stops working. And I tell you that that's the way our system, our healthcare system is. People are so, it's so difficult to gain access to primary care sometimes, especially for our population, that they'll wait till the last second. They come to us when things are broke. And I tell you, and I ask you to not sleep on this population, and for multiple reasons. Number one, it's growing, and we're seeing blurred lines. What used to be just homeless, and people had really exotic names like hobo, and it was almost like they fantasized about being free on the street. I can tell you from our clients, it's not being free on the street. It is a crisis, and it's a horrible, horrible life. And the myth that people tell you, oh, they're service resistant, they don't want help. I can tell you, our clients have been beaten up. Our number one entry into recuperative care is trauma. They've been ostracized, they've been taken advantage of, and they've been lied to for years. So if you were to walk up to a gentleman who was in the street and ask him, do you want shelter? And he didn't know you, he would be weighing out, do I want to stay on the street and safe, or do I want to go into a room with mentally ill people that I'm probably going to get robbed and taken advantage of? And I tell you, when you use that as your barometer and say they don't want help, that is a horrible misconception. So the number one myth, if nothing else from this, that you can take away is that people want help. They need help. It's the right thing to do. And the return on investment for all of us is so important that we really address it now. And we start moving forward, all of us, in our institutions and in our businesses and in our homes, to start saying, let's try to understand. Let's open up some of the areas that people can live in. And these are our neighbors. These are our friends. These are our family. And every presentation I've done this year, I usually afterwards have 2 or 3 people that come up to me and said, you know what? My son, my daughter, my friend is mentally ill. And it is a crisis, and we have to take care of it. And I'll leave you with one. I mean, I could tell you hundreds of stories, but obviously we don't have the time. But I'll leave you with one part of a movie that I heard years ago, and it keeps popping up. And to me, for me, it's a call to action. And it's one of my favorite movies, A Few Good Men. I don't know if you guys have seen that. But, there was a line in A Few Good Men that should call out to everybody in this room. And no, it's not, you need me on that wall, you have to have me on that wall, or, you can't handle the truth. Those are great lines, but that's not it. So at the end of the movie, and for those of you who don't know, there were 2 Marines that were being accused of murder. For William Santiago, a Marine who was a private. And the reason why it's so impactful, because I know many of these kids that have been picked on their whole life. And so at the end, the judge ruled that they were not to be convicted of murder. But they were to be dishonorably discharged from the Marines. And Hank, the big strapping sergeant, and the little private said, Hank, what does that mean? He said, we did nothing wrong. We did nothing wrong. And Hank looked at him and said, yes, we did. Our job is to protect the people that can't protect themselves. And so I give you today the leaders, the policymakers, the providers in this room. Our job is to protect the people that can't protect themselves. Thank you.